Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up your chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Hi, everyone. You know that feeling when you're at a party and someone asks you a brilliant question, and just as you start to get into it, someone else either comes at you or the music gets loud and it's completely out of your mind and you lose that moment. So that's what happened to us when we were guests on the Osteo Collective Expert Spotlight. We had a really wonderful time answering some questions and talking with the audience, but we ended up running out of time before we could get to all of the questions. So we did what any self-respecting group of menopausal experts that we are here, and we brought them home to continue going through them for y'all.
Welcome back to the Dusty Muffins. Today we're doing a little something we like to call unfinished business. No guests, no slides, no agenda, just 6 questions from real women that got left in a chat box.
Welcome to the Dusty Muffins. Let's get into it.
All right, ladies. Who wants to talk about bone density scans? So one of the questions was DEXA scans for women in their late 20s and 30s, and will insurance cover it? I don't know about you all. I think it's a really interesting question. I don't get a whole lot of women in this particular age group because I think there's a few specific reasons why we would do bone density scans on women this young. What are your thoughts?
Well, I think trying to get one covered by insurance for anybody under 65, because they'll only pay for it over 65 usually. So I think this goes for any woman under the age of 65, really. Definitely women in their 40s, 50s, 60s will often have a family history of their mom having a vertebral fracture or hip fracture, unfortunately. Which can, get that covered. Mm-hmm. If you've got a history of asthma and steroid use, that can get it covered.
Yeah, I've gotten it covered for long-term Depo-Provera users. Anybody who's been on Depo for more than 5 years. I haven't had any problems getting that covered, but so few people use Depo-Provera. But I order bone density studies on all of my patients when their periods start to space out by 60 days. And I don't have a problem getting it covered.
Under like symptomatic menopause or something like that?
I do N95.1 and I don't have any issues getting it covered. The only time I have anybody who has to pay out of pocket is if they don't have insurance. That has been my experience. Maybe there was one patient out there, but or patients aren't telling me they're not getting it covered.
Yeah. Issues. Anyone on Medicare or who deals with Medicare insurances, they will not all cover it under symptomatic menopause, but they will under primary ovarian failure. So that's one thing that your practitioners can use to help get it covered under Medicare. I also think too, like we think about these young athletes, right? So I always like to use my oldest daughter because she was a D run runner and very thin build, Caucasian girl. Where at one point, cycles had stopped and she was a good eater, but just very thin framed. And, I still talk to her about she needs a bone density and she probably needed one, in college, to be honest. So those types of women, I think we need to also really think about, and we don't, right? We don't think about them enough, or their primary care aren't thinking about them enough, because I think they're the ones that we need to think about, right? They're having amenorrhea because they're athletes. So any athlete that stops having their cycles are at an increased risk. So that would be one age group that would be in even, in the 20s or even younger, depending.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
You know what I find is that, a lot of women want the body composition portion of it, which doesn't come in a traditional bone density study paid for by the insurance. But I don't know about you guys, when I get some of these from these places, I feel like I'm missing part of the report. Like either they'll just give a spine measurement or just a hip measurement, but not the spine, the hip, the femoral neck. Like it feels incomplete on some of those. Like
an
you'll get
adjective
one,
fit.
you'll get one measurement. I just got one the other day and I was like, all right, well, you got one measurement and it looks okay. I don't love that for screening. I think that the radiology departments do a much better job than the ones that are looking at body composition and will give you one T-score, which of course isn't helpful if you're not menopausal. So then the bone density study is completely not useful at all.
Yeah. It's nice to have. We need kind of like all of that really to really understand what your bones are looking like, in addition to, your lean muscle mass and your visceral fat and how you're doing that way. I think a couple of the other things that go along, why you would get a bone density early would be like your primary ovarian insufficiency. So women who are, in ovarian failure early, they definitely need to be screened earlier. And, I think another thing that I think many primary care forget about too are your reflex medicines, right? Your PPIs.
Yeah.
And so those can affect your bones as well. Steroid use, chronic steroid use like you were saying, Aoife, for asthma. So if you are one of those kids, your reactive airway kids who are always on a steroid, are always sick, those are things that also put you at risk for your bone density as well. Chronic steroid use or
autoimmune diseases, like rheumatoid arthritis. A lot of people with rheumatoid arthritis have a long history of steroids, or lupus, or here, I advise my patients to go to standalone radiology clinics. There's a group here in Oregon called RAYUS, or AYUS, and it's $104 for a bone density scan if you pay out of pocket. And I think it's $199 for the body composition with the bone density scan. So it's somewhere between $102 for the whole thing, or $200 for the whole thing. What happens sometimes with these hospital groups is that they will tack on this massive facility fee. So when I went to get, just a scan of my heart, it should have been completely covered by my insurance. And I ended up paying $1,000 facility fee just because I had it done at the hospital instead of a standalone place, which really hurt, So find out if you have any of those fees if you're going to a hospital system. But I send all my patients to the standalone places because I'm so done with people getting these surprise, horrendous bills afterwards.
Yep, exactly. It just doesn't make any sense, And do you guys want to talk a little bit about the difference between Z-score and T-score when you are looking at women who are not menopausal?
Z-score is age matched to, yes. So, what somebody looks like at their peak bone density, so late 20s probably.
Right. So just something for people to understand when what to look at as well when you're getting these bone densities done, depending on your age. That's important also because it's not the same, right? It's funny though, because even, if I go and get one, it's going to report it in a different score as well, even though go months and months out, but I'm not technically postmenopausal yet.
Right. And once you're menopausal, you don't need the Z score because you don't want to compare yourself to your peers. You want
Yes.
to compare yourself after menopause to what your bones look like when you are at peak, which I've seen some people, some places report it as your 25-year-old self, and other places report it at 30. I've seen both those different numbers of when peak bone mass occurs. But um, T scores, if we graph it out on a bell curve with 0 being your 25 or 30-year-old self, anything one standard deviation plus or minus. So +1 to -1, if we were to shade it out, nobody breaks a bone with a T score between -1 and +1. -1 to -2.5 is osteopenia, the beginnings of the thinning of the bones, and then -2.5 and less is osteoporosis. And so I like to graph it out for my patients so that they can see where they are, knowing that the lumbar is typically the first place, that trabecular bone, that women will lose it in. But the femoral neck, which a lot of people think when they see it, most women assume it, it's like cervical neck. And femoral neck is that little wedge-shaped bone that connects your hip bone to your leg bone. It's a tiny little bone, and often that's where I see the greatest loss in a lot of women. And then we look at FRAX score, which is a calculation. You can use the FRAX calculator, and it's looking at that femoral neck, and then other things like your risk factors, your age, I think it has race in there, to determine what your risk is, your probability of any fracture in the next 10 years. And if your FRAX score for any fracture is greater than 20% or hip fracture greater than 3%, that's where the recommendation to be on a medication for bone rebuilding comes into place.
Yep.
So I've never seen a perimenopausal patient, knock on wood, that has needed treatment in perimenopause because their FRAX scores have been low, and not too many osteoporosis in those young women, but they do happen.
Yeah, that late perimenopausal, I've seen a few where they have fractured first and then they find out, right? So that's where, we'd rather not have that fracture. So wouldn't it have been great had they had maybe a bone density scan at 40 or 45, right? Okay, question 2. Chuckle on here. Otherwise, we could talk the whole entire hour about bones, guys. We really love our bones. So how many years post-menopause before starting hormone replacement therapy, menopausal hormone therapy is really what we like to say, is it still bone protective after 10 plus years? So we get this a lot. I don't know about you all, right? They come to you and they're more than 10 years post-menopause, which we say is, when we get the most bang for our buck for starting hormone therapy. But the question is it always bone protective? So could they still have benefit for their bones?
I don't think we
say yes, right?
Yeah.
Yeah.
I don't think there's any age where estrogen stops working at your bones.
You got it. 100%.
A lot of the bone studies are done on older women, in their 70s and 80s.
Yeah. So doesn't it make sense if we have this huge high mortality and morbidity risk for women who fracture a hip, why we are gatekeeping and honestly not having a very, very serious conversation with them about their risk benefit about starting estrogen to protect their bones? It just doesn't make any sense to me, right? We just, a lot of, not the three of us, but there's a lot of either academics out there, whoever, get a little worked up about starting estrogen more than 10 years post-menopause because, of this risk out there. But yet there is such a high morbidity, mortality risk for women who break a hip.
Calling all local muffins. Come to Portland on July 23rd. I'd love for you to join me at OMSI for a special screening of the M Factor 2, Before the Pause, a powerful new documentary about perimenopause. We'll watch the film together in the Empirical Theatre, and afterwards I'll be hosting a live Q&A where you can ask all those questions you've been saving for Google at 2 a.m. Whether you're in perimenopause yourself, supporting a partner, or just want to understand what's actually happening to women's bodies and brains during this transition, this is for you. Tickets are available now through OMSI, and we'd love to see you there. Join us for an evening of science, storytelling, myth-busting, and hopefully a few laughs. We'll see you all at OMSI. Do you think if we said to men, 50% of you over the age of 50 will break a bone because of low bone density. But if you start your testosterone, that won't happen. You won't end up in a nursing home. You won't have a 20% risk of dying over that first year after that fracture. Mm-hmm. Do you think there will be any doctor that didn't explain that to men and give them an informed choice to start or not to start testosterone, depending on what they felt was best for them personally? No.
Right. It doesn't make sense. I sit there and I talk with, patients, and I'm just like, it doesn't make sense. And the more that you talk it out, you're like, this doesn't make any sense. You may not get all of the heart protection and all the cognitive protection, all the metabolic protection that maybe you would have got had you started it within those 10 years. But, if your benefits outweigh the risks of them starting a transdermal low dose estrogen patch at the very least.
Yeah. And, the bone density scans take a while to change. So I have some patients who are watching their bone markers. So their CTX and the P1NP, which are two blood markers. And you see, even on low doses of estrogen, the CTX dropping dramatically. Unless you go up to higher doses, I don't see the P1NP increasing. So the CTX is bone breakdown, a marker of bone breakdown. So what you want to see is that dropping when you're treating bones. And the P1NP is bone building. So it would be amazing to see that increasing when you start hormone therapy. But really what studies show is that you have to be on a higher dose of estrogen to get that bone building. But the lowest doses can stop the bone breakdown. But also what you're watching is the ratio of CTX to P1NP. And so as the CTX comes down, that ratio changes, which is really healthy for your bones too. So I just have these women in their 70s and 80s who are watching those markers, and you are seeing them change in real time. And it's phenomenal. And they've all been to endocrinologists who have offered them every bone drug under the sun except hormone therapy. And I am so happy we have all those bone drugs. I will take all the tools you can give me for my tool belt. Thank you. But each woman deserves a conversation about anything available to her, right? Which includes hormone therapy, because every single one of those bone drugs comes with risks.
Right.
Big risks.
And the fact that all you're doing on those bone meds is mummifying the bone. You're not actually building it. You're just freezing it. So you're not ever going to see market improvement. You're not going to see improvement on those drugs. We're just trying to make sure that things don't get worse. But, the other thing that I find really interesting is two things: how we have normalized fractures over 40, how many patients that I have talked to that broke a leg. I mean, toes, okay, lots of people break toes, but are breaking a leg, breaking a forearm for just a simple little bump and fall, and nobody does a bone density study, or the number of providers who will start on bone medications right out the gate, but never also check any of these bone turnover markers, which, was a new thing for us until we heard, Dr. Doug Lucas really talk about those bone markers. And so I think there's some big gaps where patients can really educate providers that are probably behind on both of those things. It just drives me crazy.
Isn't it? Yeah. They always say, oh, well, I fell. And I'm like, well, you didn't fall very far from
Didn't drop out of the sky.
Like, yeah. I'm like, that's not normal. And how did no one say anything to you?
One of the last patients. Oh, sorry.
No. Yeah.
I was just going to say I had a relatively young female who sent me all her info before she came to see me. And one of the things she sent me was x-rays of her hands, which showed osteopenia. I was like, osteopenia in your hands? I was like, did anyone even check to see if you had celiac disease? Maybe you're not even absorbing any calcium or
Right.
nutrients, And she was like, no,
That's
people
pretty
just,
advanced.
yeah. I mean, so the radiologist just reported, oh, this 40-year-old has osteopenia in her hands, which is, we don't see, until things are very advanced. And that was just like file away in her chart. And she had all these other things going on too, which could have pointed towards something like celiac disease, whereas if you find it and treat it, you can get your normal bones back, for instance.
And so I think that sets me
Totally
off on that
normalized.
other tangent of a lot of this, I think, is because of the way traditional medicine is, and you are a revolving door, and these practitioners cannot get through everything because they don't have enough time to get through everything. So things like that either get overlooked, they get missed, they get brought up later, whatever it is that is failing women and failing clinicians who are stuck in that environment. Okay.
Next. Let's go. You were right. All right, let's have question 3. I'm embarrassed enough to admit that I didn't know that this was a supplement until last week when someone else asked me. But what about pregnenolone instead of testosterone? My DHEA and testosterone moved into normal range with pregnenolone alone.
Yeah, I've not used it.
No.
That makes no sense to me, but
I did look it up on FullScript because I was kind of curious about I was just kind of curious about it. And it's touted as the grandmother of all steroid hormones, since all steroid hormones, over 150 of them, are derived from pregnenolone. And it has been linked with positive support of the immune system, mood, and memory. In the body, it is converted to DHEA and or progesterone, and is likely that the body will convert pregnenolone appropriately according to its needs. And so I think it becomes expensive P. I would never substitute it. But the other thing that I learned that I did not know is that if you have a history of seizures, you should not be on pregnenolone.
Interesting. And isn't it kind of, it seems a little bit to me kind of like that DHEA, like you give it, but you really don't know how your body's going to use it and break it down, right? So if you need testosterone, I personally, and it doesn't mean it's the right way and the only way. If you need progesterone, I'm going to give you progesterone. If you need testosterone, I'm going to give you testosterone. If you need estrogen, I'm going to give you estrogen. Yes, I do like to use DHEA for like my vulvar vaginal type stuff, but I also don't typically give it orally to my patients. And maybe that's just me just like, hey, I'd like to know how you're going to use it. And I just need to give you the things that you need.
Yeah. I think when we all took some of our training in functional medicine, that we were taught that the goal of DHEA was, to get someone up to 350, like 350 was the target level for DHEA. And I have found that in perimenopause, it can be a stopgap. Occasionally I've given it, just until I start them on testosterone. But most of the time, whether it's pregnenolone or DHEA, all you're going to cause is side effects like acne and oily skin that women don't like. And so I don't know. I think it starts to become expensive P. I agree with you. I prefer to give the hormone and then try to figure out if something might actually work. Have you been told your labs are normal, but yet you still feel exhausted, foggy, and gain weight simply by looking at a meal? Well, you're in good company. In midlife, normal isn't enough. You deserve to feel like yourself again. I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and certified menopause specialist. I deep dive into the areas often overlooked: hormone optimization, thyroid health, gut health, medical weight loss, including administering testosterone therapy for women. No rushing, no insurance hoops, just a blueprint back to a vibrant life. I'm accepting new patients in Virginia, Florida, and 5 other states. Book your clarity call at www.christinehartkressdmp.com.
Yeah. How about you, Aoife?
Yeah, I think if someone was really against taking testosterone for some reason, then I think DHEA would be really reasonable to try and see if they got any improvement from that. I've definitely met women who said they do. So yeah, I think it's another, like I said, another tool. Progesterone intolerance, IUD works, oral and vaginal don't. Concerns about synthetic progestins and family history of breast cancer. Okay, so for most women, I would say when they take oral progesterone, it's broken down in the gut, it's metabolized by the liver, and the liver turns some of it into allopregnanolone. And that goes up in the bloodstream, crosses the blood-brain barrier, and activates our GABA A receptors in the brain, which stimulates rest and relaxation for most women. But for some women, it has this paradoxical reaction where it agitates them and they don't feel good. I've actually had patients who had that when they initially tried progesterone. We stopped it, took a break, went back on it. Might have even happened the second time, took a break, went back on it, third time, no problems. They loved it.
Yeah.
Like, it doesn't seem to be, just because you have it once doesn't mean you can't ever take progesterone again. I have found with my patients. So don't worry if this sounds like you, because it doesn't mean you can't tolerate it forever. So then we can do different things, right? So we can give it so that it is not broken down in the gut and goes through the liver. So you can do that by putting the same capsule that you would put in your mouth into the vagina or the rectum. And that way it skips being metabolized, or, skips going through the liver through via digestion. And you don't get that conversion to allopregnanolone. Other than that, the other option is to use a synthetic progestin.
Or the IUD. I don't know what they meant. IUD works, right? The IUDs.
The Mirena.
Well, work. We know what, roughly 20% of them you'll have cessation of ovulation because it goes systemically versus just a local effect. I agree with Aoife as well. I'll have patients that sometimes they will just grin and bear it for a month and they're like, and then all of a sudden I'm good. And you feel, I feel bad because they have like some GI gas and bloating. And now that's not necessarily intolerance. It can be side effect, just, progesterone. That's part of progesterone. I will see like breast fullness as well, and water retention. So I try to tell women, do you cycle it at first? Do you go every other day, every few days? There's a few different things sometimes that I'll try, or lower dosing if we use a compounding pharmacy, if they really can't tolerate it and it doesn't go away for, by about 4 weeks. Or if it's really terrible, then sometimes I will just really back off and just go super, super slow. And then eventually they can work their way up to the normal 100 milligram micronized progesterone. Not always, but sometimes. So
in Ireland, if you're perimenopausal and you're still having periods every month, your doctor will put you on the progesterone, for 14 days of the month and then off for 14 days. So like a 28-day cycle.
Yeah.
And so what happens is, you go to your doctor to start hormone therapy. They give you your estrogen and your progesterone. They say, come back in 3 months. And so these women are taking 200 milligrams of progesterone, having been taking nothing for 14 days of the month. And they're like, oh my God, I feel awful. My boobs hurt. I'm so swollen. But then by the time they come back 3 months later, all those side effects have gone. Their body has gotten used to it.
So they're good.
They're all fine. Yeah.
So maybe we're just seeing them too early.
Not to see people too early.
Yeah. Yeah. No, I think that's true too. That's where you have
too early.
Yeah. Yes. Yes. I think that's really important.
And I do think that there has to be you have to also, be able to tolerate a little bit of getting acclimated.
Yes.
Before, completely giving up and saying it doesn't work for me. And what I try to remind patients is when your ovaries were working full speed, when you were premenopausal, before menopause, you were making way more progesterone, estradiol, testosterone, and you were doing just fine. So the likelihood of you not being able to tolerate the medication, which is structurally the same, is pretty unusual. The vast majority of women tolerate it just fine. You just have to be, especially in perimenopause, get your head wrapped around every day is not going to be perfect.
Right. Because you're not menopausal, right? So those fluctuations are going to occur above and beyond the hormone dose that we are giving you, right? It's always, I always like to, it's that cushion, but we're not controlling those ovaries, ladies. So when you're feeling horrible, this just happened to me probably a week ago. I was dropping everything. I couldn't find my glasses on my head, couldn't find my phone that I was talking into. My kids are making fun of me. And then I like cycled this like a couple days ago, and I was like, oh yeah. Because you forget when you go so many months in between, then you totally forget. And then it makes sense. So, you know, you could start flashing, you know, above and beyond your medication or your hormone therapy. You will still have those fluctuations. We cannot control those. And so sometimes, you know, taking that time again to continue to educate our perimenopausal women that it's going to be better, or try to remember, or look at your green scale score. You know, is it better than when you started? Probably is, but you're not going to be perfect every time,
that
right?
menopause questionnaire is so important. What I keep forgetting to say to patients is that, you know, I do this 6-month program and I see my patients every 6 weeks. And I never remember to say to them, this takes time. And there's a couple who have come back to me 6 weeks after the first time I saw them. And I'm sitting there going, this woman seems really pissed off. Like, I wonder what's going on. And she's like, so I'm not like better yet. And like, you look at the menopause questionnaire, it's gone from 45 out of 69 to 20. And I'm like, yes, that is a massive drop. We are doing amazingly.
Yep.
And she's like, it's 6 weeks later and I'm not feeling back to normal again. I'm like, oh my God, like it never occurs to me to say to people, this does not just take 6 weeks.
No.
This takes
and
months.
and in perimenopause, you're not going to feel back to normal all the way. You know, and every woman is so different. We don't know
it's not magic.
what you'll get back to. Yeah. So
at 6 weeks, I'm just making sure that you're not worse.
Yes. Yes.
Bleeding all over the place.
Right.
Yeah.
Right.
Yeah.
And, you know, I think the other thing, you know, that I think both for clinicians and patients, that if they do have a progesterone intolerance and they're perimenopausal, they don't need to be on a progestogen. They could just be on some estrogen and testosterone until those periods start to skip out, because, you know, we love progesterone for mood and sleep. And if you can't tolerate progesterone, mood and sleep may not get better for you, because the synthetic progestins won't work for that.
Right.
But ultimately, you know, aside from mood and sleep, the whole purpose is to protect the lining of the uterus. And if you're bleeding, you're making plenty of progesterone. So it can be a later problem, or also compounded starting much slower at 25 milligrams and trying to go up every, you know, 2 or 3 weeks by 25 milligrams is another way to help patients acclimate. But unfortunately, we don't have those low doses in the regular pharmacy.
Yeah. Or cycling it, right? Sometimes that is when it's cycling and it works really,
I've
really
never
well.
been brave enough not to use it.
Oh yeah, I have. In my women who are cycling regularly, I will have them, especially if they're on lower doses of e-patches. I'm like, you are producing progesterone because you're having a regular cycle. You're not having that breakthrough bleeding. You're not having, you know, because sometimes that breakthrough bleeding is if they don't have enough progesterone too. But if you're going pretty regular and you're not cycling out, then I have not too many.
No, because everybody wants mood and sleep.
Everyone, yeah.
That makes logical sense to me. Yes. Yeah.
And to answer the last part of that question, family history of anything is not a contraindication for being on hormone therapy. But the synthetic progestins, is statistically insignificant, or a theoretical risk with the synthetic progestins that we saw in the Women's Health Initiative of breast cancer, but 0.9%, so very, very low. With the synthetic progestins. That's why we like progesterone, which isn't associated with an increased risk of breast cancer. But really, you know, one thing women could consider to do is myriad testing if they have a family history of breast cancer and they're not sure of the significance of it, and see if they have any of the, if they have a BRCA mutation or any of the other derivatives. So.
The way I explain the synthetic progestin and breast cancer is the worst. So the synthetic progestins are on a scale, right? Some of them cause a very slight increase in breast cancer risk, and some of them a much higher breast cancer risk. So say we take medroxyprogesterone acetate, which is the highest increased risk of breast cancer. It means your risk would go from 4 out of 1,000 women per year. So in the general population, not on hormone therapy, 4 of those women out of 1,000 will get breast cancer. And then on the medroxyprogesterone acetate, the worst one you could pick, it goes to 4.8 women out of 1,000 each year. Yeah.
Yep.
It's really small. Mm-hmm.
That is small.
That's great. All right, number 5.
Yeah.
What are your thoughts on injectable testosterone and or estradiol? I don't do a lot. I haven't had to yet.
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
I think it would be very difficult to use the FDA-approved injectable testosterone and get ranges in the normal female range for women. I think if you have a woman who's using testosterone and she likes to be up around 150 or 200, which some practitioners are comfortable with, then you could switch her to injectable and probably get those same levels. But I think it would be harder to keep people down where I usually keep them, which is usually below about 100 or so, with injectable.
Yeah, I don't find that most women need it, but I think it's an option. The challenge is most clinicians haven't been trained in it.
Mm-hmm.
And even when you've been trained in it, you have to go and look at it because you don't do it that often. And you can get really great levels. I think some of the like Defy, I know, does a lot of injectable testosterone and estradiol.
Yeah.
But then when I get those patients, they're usually, like you said, really high. But occasionally, I do have a patient on injectables. But I think it also involves a long-term relationship, because when you prescribe those medications, the only way to give those is in, like 6, 8, 9, 12 months of medication. And so you have to, I know for me, I want to have people seeing me and coming back. But there's a place. It just isn't for everyone.
Yep. What's Defy, Christine?
It's like one of those telemed companies. It seems like everybody needs injectables, which I do not think is the case.
So are they using compounded?
Yeah. And even I looked at it for the regular pharmacy, but then you have to, it comes in powder. You have to you have to reconstitute it. It's easier to do the compounded because it already comes already made, and you can dose out, twice weekly or once weekly or however you're going to do it. I don't know. It's something I would like to learn, so I have that in my toolbox, but it's one of those things I just have I've never done before. And so I think it's, I don't know, maybe there's a place for the people who do it all the time.
The other thing is, after using the gel or cream for a few weeks, it reaches a steady state in your bloodstream. And each morning when you apply it, you get a little spike and then it goes back down to your regular level. But with the injectables, then you're getting quite a big spike and then sometimes a dip as well. Yeah, which for some women can make you, not feel great.
Mm-hmm.
No. My big plug for Androgel. I'm really loving Androgel.
Yeah.
It's so easy.
So Androgel is the big bottle and you do 1/4 of a pump a day. So you're not bothering with little tubes or those bloody packets, ketchup packets.
Yeah, the packets
and it's cheaper. It's only at most $40. Yeah. For 250 day supply. So easy.
Again, I have a problem with you have to make sure that your patient is following up for
because that's
blood
a long
work.
time to give
somebody the FDA says we can give testosterone in 30-day supply.
Yeah.
And if you go and you got to go back to the pharmacy every 30 days to pick it up. And here's us then given the testosterone in a 200 or 300-day supply, trusting our patients to follow up. and often they will disappear.
Yeah, that is true. All right, last one, ladies. Cyclic versus physiologic BHRT. What's the difference and when is each indicated? It was a little interesting when I was trying to read this because physiologic BHRT really is mimicking your natural cycle in a woman when you are having your natural cycles, right? Your estrogen goes up and the progesterone goes up and they fall down. So that's physiologic hormone therapy.
You know, you know what that might be referring to though
Yeah.
is like, right, are you talking about with the making you bleed till death?
Yeah, that's physio.
Yeah.
Yes, exactly. That's a physiologic. So you mimic your natural menstrual cycle for however long. And the training that I had on this, actually, they really do like this for perimenopausal women. And not necessarily menopausal women, at least in my training, they had said that by the time, really menopausal, you can go down to just menopausal hormone therapy. And then I wondered if cyclic just means like cycling progesterone.
That's what I would guess.
That's kind of what I thought it as, where you can just use micronized progesterone 2 weeks out of, so you're on normal like estradiol, a normal like patch, and I guess I cycle that sometimes too. So, you can cycle your progesterone for 14 days out of the month. You can also cycle your estradiol for when maybe it's that luteal phase when your estrogen is low. So that would be different. That's menopausal hormone therapy that you are cycling in a perimenopausal woman versus physiologic BHRT, where you're mimicking the menstrual cycle with high doses of estradiol a certain time of the month, middle of your cycle, and higher progesterone. And then you are clicking things up and down as those 30 days of a menstrual cycle are going and mimicking that. Ladies, am I reading that right?
Yeah, I think that's what it means.
I'm just trying to find our podcast episode with Emily Sadre.
Okay. Mm-hmm.
Yep.
Yeah,
that was a great one. She talked all about that.
Because we talked all about that.
I mean, I think, there are so many different ways to, get women their hormone therapy, because every woman, as we always have said, is unique. And what works for one woman may not work for someone else. But I think, some of these, injectable testosterone, physiologic BHRT, requires the right trained provider. You're probably not likely going to find that with your traditional GYN or primary care. And as you can see, even those of us that are deep into this space, haven't embarked wholly on some of these other options, just because, it's already so complex, right? And it's, more training. And so you're really looking for someone pretty specialized to do that. Not that they're not out there. It's just going to be a little bit more complex because, 90% of what we do works for 99% of the women.
Yeah. And physiologic BHRT really is, you have to really be ready to do blood work and do the click, the clicks up and down. And it is a regimen. So it's not, a one and done. It is a regimen, and you need to get your blood work done at certain times so that you can adjust your dosing and go up when you need to, go down when you need to. So, it can be really wonderful for certain women, but it's not, there's a very nice, it's a science to it for sure.
If you want to know more about that physiologic HRT, our episode was on April 5th with Emily Sadre, and it was called From Guesswork to Precision, the future of hormone care with Aurelia Health. So she teaches us all about that in that episode.
Awesome.
And, now we have 2 other things that we, can add to our long list of thousands of hours of education that we already have, right? But I think too, for our listeners, what we're really excited about, which is at least for me, maybe it take me a little longer to get updated on those, completely updated on the injectables and the BHRT, is we are all taking McCall McPherson's thyroid. We're all in cohort 1. So I'm really excited about that. So that's going to be my focus for the next 6 months.
Yes, same. I'm excited too. So the muffins are all in, and we'll be thyroid experts here pretty darn soon.
I know, it's exciting.
That's a wrap on the questions we didn't get to. To everyone in the Osteo Collective community who submitted those questions, thank you so much. They're not small questions. They're the questions that matter and real answers.
If you have more questions like these, send them our way. This is exactly the kind of episode we love making. No fluff, no filler, just the stuff you actually want and need to know.
If you enjoyed today's episode, please take a moment to follow, subscribe, rate, and review the Dusty Muffins wherever you get your podcasts.
Those ratings and reviews might seem like a small thing, but they help us reach more women who are sitting at home wondering if they're the only ones struggling with hot flashes, brain fog, sleep issues, weight changes, low libido, anxiety, or all the other delightful surprises that hormones can throw our way.
Share this episode with a friend, your sister, your partner, your colleague, your mother, or that woman who keeps saying she's fine while surviving on caffeine and sheer determination.
The more we talk about these topics, the more women realize they're not alone and they're not imagining it. There are often solutions available.
Until next time, take care of yourselves, take care of each other, and remember, life may make us dusty, but we're not done rising yet.